In this video, we will do an exam review on the adrenergic receptors, including the basic and clinical knowledge, few important exam questions that will be answered throughout the video. So number 1, why does orthostatic hypotension occur in pheochromocytoma? Number 2, what is the receptor response on increase or decrease catecholamine levels? Number 3, which second messengers are involved in the activities of the adrenergic receptors? Number 4, what's the difference between alpha-1 and alpha-2 agonist functions? Number 5, which medications are non-selective combined alpha-beta antagonists? Number 6, what is the effect of adrenergic blocker? Number 7, what are the functions of the beta-1 blockers? Number 8, which receptor activation increases cyclic AMP? We will begin the discussion with adrenergic receptors. There are 3 types: alpha, beta, and dopaminergic. Alpha receptors are alpha-1 and alpha-2. Beta receptors are beta-1, 2, and 3. And dopamine are D1 and D2. Receptors are at the effector cell surface in the extracellular space. Activities of the adrenergic receptors are mediated by number 1, G protein, guanosine proteins, and number 2, by second messenger inside the cell. They include cyclic AMP, calcium, inositol pyrophosphate 3, phosphorylase, and diacylglycerol. Number 3, epinephrine, norepinephrine, and dopamine are stored in the granular vesicles and released in the synaptic cleft. Number 4, epinephrine and norepinephrine are agonists for all adrenergic receptor subtypes. Number 5, norepinephrine is synthesized at the nerve terminals. Epinephrine is synthesized in the adrenal medulla, not in the nerves. Why is epinephrine not synthesized in the nerve endings? So I'll briefly describe the synthesis of the catecholamine, which starts here at phenylalanine, to tyrosine, to dopa, then dopamine, then norepinephrine, and then adrenaline. So this enzyme, PNMT, which stands for phenylethanolamine N-methyltransferase, is present in the adrenal medulla and not in the nerve terminals, which is why it converts the norepinephrine into adrenaline in the adrenal medulla. And if you see here, dopamine is precursor of norepinephrine. You can see dopamine is the precursor of norepinephrine, and norepinephrine is the precursor for adrenaline. So which receptors are activated by sympathomimetics? We have alpha receptors that are activated more by norepinephrine than by adrenaline. And we have beta receptors activated more by adrenaline and more by isoproterenol. They're most responsive to isoproterenol. So alpha receptors are more activated by norepinephrine, meanwhile beta receptors are activated more by adrenaline. Number 8, alpha-1 and alpha-2 receptors are postsynaptic in the arterial and venous vessel and cause vasoconstriction. Alpha-2 receptors are at the presynaptic nerve membrane as well. Number 9, alpha-1 and alpha-2 are postsynaptic. However, alpha-2 is also found at the presynaptic nerve membrane. Number 9, presynaptic alpha-2 receptors act as negative feedback controllers by inhibiting norepinephrine release, which makes them sympatholytic. Number 10, alpha-1 agonists lead to vasoconstriction and increased blood pressure, whereas alpha-2 agonists are sympatholytics and decrease blood pressure. Alpha-1 stimulation increases blood pressure, and alpha-2 stimulation decreases blood pressure. Number 11, beta-1 are in the heart. They're cardioselective and also in the kidneys. Beta-1 stimulation in the heart increases the rate and force of contraction. Meanwhile, beta-1 stimulation in the kidneys increases renin production and leads to increased blood pressure. So let's discuss beta-1 and beta-2 blockers. Beta-1 blockers decrease the force and heart rate, and in the kidneys they decrease renin production, which leads to decrease in blood pressure, and they're used as hypertensive for that reason. On the other hand, we have beta-2 receptors. They're in the heart, lung, liver, uterus, and GI vascular smooth muscles, as well as skeletal muscles. Their stimulation leads to bronchodilation and vasodilation. Beta 2 blockers cause bronchospasm and cold extremities due to unopposed alpha 1 vasoconstriction. Number 14. Beta 3 receptors are present in the adipose tissue and cause lipolysis. Beta 3 stimulation causes weight loss. Number 15. Dopamine receptors are of D1 and D2, and in the autonomic ganglia and in some brain parts, catecholamine synthesis stops at dopamine. See here in the synthetic pathway, dopa was converted into dopamine, which converted into norepinephrine, converted to adrenaline. Now moving on to mechanism of action of receptors. Let me describe the beta receptors and D1 receptors first. They activate adenylate cyclase and increase cyclic AMP. Then we have the presynaptic alpha 2 and D2 receptors. They inhibit adenylate cyclase and decrease cyclic AMP and decrease norepinephrine release. Now alpha 1 stimulation activates phosphorylase C, which increases intracellular calcium that stimulates protein kinase. So all beta receptors and D1 are going to increase cyclic AMP versus alpha 2 and D2 will decrease cyclic AMP and norepinephrine, and alpha 1 stimulation activates phosphorylase C, which increases the intracellular calcium. Okay, effects of catecholamines on receptors. First, when we have increased catecholamine, it decreases the number of receptors, which leads to a decreased response to catecholamines. That's why orthostatic hypotension in pheochromocytoma is due to decreased receptor despite having increased norepinephrine. So increased catecholamine as it occurs in pheochromocytoma is going to decrease the number of receptors, and that causes orthostatic hypotension. Number 2, decreased catecholamine increases the number of receptors, which leads to increased catecholamine response. And number 3, chronic use of adrenergic blockers increases receptor, which leads to increased response to catecholamine. So withdrawal of these agents produces hypersensitivity to sympathetic stimuli. So abrupt withdrawal of beta blockers produces rebound hypertension. And abrupt withdrawal of clonidine, which is a centrally acting alpha 2 agonist and acts like a sympatholytic, may cause rebound hypertension due to upregulation of the receptors. So to review, increased catecholamine will decrease number of receptors, decrease the response to catecholamine, and decreased catecholamine will increase the receptors, which will lead to increased catecholamine response. And adrenergic blockers will increase the receptors and increase the response to catecholamine. So withdrawal of these agents produces hypersensitivity to sympathetic stimuli. Withdrawal of beta blockers will produce rebound hypertension. Now let's answer those questions I asked you in the beginning of the video. Number 1, why does orthostatic hypotension occur in pheochromocytoma? That's because catecholamine high levels decrease receptors and the response decreases to catecholamine. That causes orthostatic hypotension in pheochromocytoma due to decreased receptor despite increased norepinephrine. Number 2, what is the receptor response on increase or decrease catecholamine levels? When there is increased catecholamine, receptors decrease and the response decreases to catecholamine, versus when there's decreased catecholamine, the receptors increase and the response to catecholamine also increases. Number 3, which second messengers are involved in the activation of the adrenergic receptors? We have cyclic AMP, calcium, inositol pyrophosphate 3, phosphorylase, and diacylglycerol. Number 4, what's the difference between alpha 1 and alpha 2 agonists? Alpha 1 agonists are going to vasoconstrict and increase blood pressure. Alpha 2 agonists are sympatholytics and going to decrease blood pressure. Alpha 1 stimulation dilates pupil. Alpha 2 stimulation constricts pupil. Number 5, which medications are non-selective combined alpha and beta antagonists? Labetalol, carvedilol. Number 6, what is the effect of adrenergic blockers on the receptors? Adrenergic blockers increase number of receptors, which leads to increased response to catecholamine, and withdrawal of these agents produces hypersensitivity to sympathetic stimuli. And abrupt withdrawal of beta blockers will lead to rebound hypertension. Similarly, abrupt withdrawal of clonidine, which is a sympatholytic, centrally acting alpha-2 agonist, decreases norepinephrine, which causes rebound hypertension due to upregulation of receptors. Number 7, what are the functions of the beta-1 blockers? Beta-1 blockers are going to decrease force and heart rate. They're going to decrease stroke volume and decrease cardiac output. And in the kidneys, decrease renin production, which will lead to decreased blood pressure. They are mainly used in ischemic and arrhythmic cardiac conditions, as well as hypertension. Examples of beta-1 blockers are atenolol, esmolol, metoprolol. Number 8, which receptor activation increases cyclic AMP? Beta receptors and D1 receptors activate adenylate cyclase and increases cyclic AMP. Alpha receptors and D2 receptors don't stimulate adenylate cyclase. Presynaptic alpha-2 and D2 receptors inhibit adenylate cyclase, which decreases cyclic AMP and decreases norepinephrine.